you want to have the patient start working on something to fix this issue. They had 8-line drop, whatever, on your dynamic visual acuity test, so you measured all that. So where do you start with treatment? So the number one treatment for this is something called VOR, viewing times 1. Some people call it times 1 viewing, some people call it X1 viewing, some people just call it VOR. But basically, all it is just like the slow VOR test is basically turning that into an exercise. So somebody's looking at a target. Most commonly, it's like a post-it on the wall. Some people use your thumb. I far prefer like a post-it note. So you would be looking at a target, post-it or otherwise, light switch, whatever, and you're turning side to side. You also do up and down. But the goal of this exercise is to increase their dizzy symptoms slightly to a tolerable amount. So basically what we want to see you do with the patient is assess what their baseline dizziness is, and they're like, oh, if I'm just sitting here, I'm like a 1 or a 2 or something like that, is hopefully what they say, and not like an 8 or something. And then you'd say, okay, I want you to increase this, but maybe not more than like a 3 or a 4. So just educating the patient, because if you don't tell them, they're just going to be like, hey, your thing didn't help me, it just made it worse. But they need to understand that they're going to feel it get a little bit worse, but it also isn't like torture yourself, like situation, and that's going to get you better. That's just going to set them back more. It's not going to be helpful for them. So you're looking at a target and you're coaching them to go side to side and also up and down. How you dose this is based on whether they have a chronic hypofunction or an acute hypofunction. So if it's been 3 months or less, that's considered an acute vestibular hypofunction, and they need to do at least 12 minutes a day of this exercise with all of it combined, up, down, side to side. 12 minutes a day is what the research in the clinical practice guidelines shows that they need to actually make a difference. So if it is chronic, meaning that it's going on for longer than 3 months, 20 minutes a day is what the research says. It's been going on for a longer time, they have to do more to make it budge, to get better. Some patients will be like, that's ridiculous, like that's so much. And these are not fun exercises to do, to be honest. Like usually they're not fan favorites from the patients. But tell them like it's not my 20 minutes. It's like that's what the research says. You can try 15 and see what happens, and, but I have no. Why wouldn't you just do 20 and just make sure that you're going to get better from this? So.
And that's broken up. It could be broken up like space.
Absolutely, yeah.
Okay.
Yeah. So usually, and everything that I'm about to say is not in the clinical practice guideline in terms of all the ways you can adjust it. It's just using your clinical reasoning, basically. So there are so many variables that you can change for these exercises, and you've probably seen some of your CIs or seen other people do them, like, oh, you can do VOR on one leg, and you can do VOR on an AirX pad, and you can do VOR while you're doing convergence and divergence, and you're like looking and moving and doing all this stuff. So where I personally start, just to keep things standardized and basic, is I say, do it at your own pace in a tolerable way until you can consistently get up to 1 minute before you have to stop. Before you're hitting that 4 out of 10, for example, and you have to stop. So a lot of times, people's first go at it, they're doing this, and they're just like, yeah, like that makes me feel, that's like why I'm here, is to treat like this yucky feeling that I have right now. And say they made it 20 seconds. So that, I don't want them to push past that because I'm trying to get to a minute, but I want them to stop, and then once they can practice and keep doing it, and they don't hit that 4, and they hit a minute first, then I start practicing, or we start progressing speed. So that same metronome that I used, I'm not putting it at 240 like I did for Marjorie to do the test, because that's a standardized. I have to do it at 2 hertz But I'm pulling it way back, maybe 60, which is about 1 turn per second, and I'm having him start there, and having him time it for a minute. I like this app because it just has a timer and it'll stop. You don't have to look at it. You can stop it on your own. That's how they can objectively have a metric to measure speed, because every single vestibular patient will tell you that moving faster is more disorienting, more symptomatic than moving slower. So this is how you can chip away at that. You guys have probably heard somewhere along the way that measurement equals motivation. So this is like a way that the patient can grade themselves up at home. They don't have to wait for what you're going to tell them at the next visit. They can, okay, I did 60 and I'm good, and that doesn't bother me anymore. I'm going to do 70. I'm going to do 80, and we just keep chipping away at it and getting better and better that way. Those are the two main things that I progress. If necessary, I'll add the other stuff. You're doing tandem stance VOR. You're doing walking forward backwards. You're doing it with a busy background. So that's when you're like getting something like this. They call this a busy bee. And you basically, this is your visual target, and then you have a checkerboard behind it, so that's going to bother people more. So that's, once they're getting more advanced to that level, and they're saying, hey, you know, I'm doing exercises, I'm doing so good, I'm doing 120 beats per minute, doesn't bother me, but like when I go to a concert and there's people everywhere and I'm trying to find my friends, that like really mess me up. And you're like, okay, easy, busy background, like we can simulate that in an exercise and promote that more. This is a checkerboard. I'll have people pull strips of wrapping paper and then use that and then put their little target on it. I'll have people, there's all kinds of torturous things on YouTube with like spinny, crazy patterns. If people have more problems in the car, I'll have them throw it on the windshield and do it in the car, like while their family member's driving. Like just getting more specific to the patient and what's bothering them. Yeah, so those are all options on how you can progress that VOR exercise. And basically what I tell people is like, this is what's going to take away your dizziness. This is like the number one thing. Like you do this for 12 minutes every day and you're dizzy, and you keep progressing, your dizziness should be gone in 4 to 6 weeks. That's what the CPG shows. For chronic, more like 10 to 12 weeks. Takes a little while. So, but I really, even though it's like not the most exciting thing to do, what is exciting and where like makes a huge change in people's lives, and that's when people start crying and stuff, is like to be dizzy all the time and to not have to be dizzy anymore is like pretty big for a lot of people. So I feel like you could change a lot with people, and they're pretty thankful once they understand it, and that's when they do get more motivated, even though it's not an exciting exercise to do, to like do it and just to get rid of it. So yeah.